Hello, and welcome to the Pediatric Pharmacy Association's core competency on diabetes mellitus. My name is Kevin Lanabaugh, and I am a clinical pharmacist in pediatric ambulatory care at the University of Virginia Children's in Charlottesville, Virginia. I'm joined today by Logan Graves, who is one of our incoming PGY1 pharmacy residents. We have no conflicts of interest or any kinds of disclosures with the material presented within this presentation. We are going to cover the following objectives. So we're going to be talking about the differences in the pathophysiology between type 1 and type 2 diabetes mellitus. We'll be talking about how we design appropriate treatment regimens for patients based on their presentation with either type 1 or type 2 diabetes. And then we'll also be discussing hypoglycemia, learning how to recognize that, as well as what we need to do in terms of treatment for hypoglycemia. So to start out with, diabetes is something that is at the forefront of American society. It's a common disease state of which 37.3 million Americans are diagnosed with, and that represents about 11.3% of the entire US population. Now, of those 37 million Americans, up to a third of them may be actually undiagnosed. So there's perhaps a lot of patients out there with diabetes who don't even recognize it. When we look at the data for type 1 diabetes mellitus, we see that there are about nearly 2 million Americans with type 1. So it makes a small fraction of the total amount of patients with diabetes. In terms of the pediatric population, it's a little bit less common. We have about 283,000 children with diabetes. Although when we subtype those patients, we see that there are actually more patients with type 1 in the pediatric population, as about 86% of children have type 1 diabetes mellitus. It's important to note that the incidence for diabetes is increasing, both for type 1 diabetes mellitus and type 2 diabetes mellitus. There's a lot of attention for pediatric patients in the wake of growing obesity about the increasing number of type 2 patients, but we actually see an increased incidence between the years 2000 and 2015 for type 1 diabetes mellitus as well. So the latest estimates are about 18,000 new children each year with type 1 diabetes mellitus and about nearly 6,000 with type 2. Because we know that the incidence is increasing, it's very important that we understand what the screening looks like and who needs to be screened. So the American Diabetes Association does list out particular screening criteria that we should be aware of. All patients who are either overweight, which means that their body mass index is greater than or equal to the 85th percentile, or those who are obese, meaning that their BMI is greater than or equal to the 95th percentile, who have at least one additional risk factor, which will be described on the next slide, should be screened, starting at the age of 10 or the onset of puberty, and this should occur whichever is earlier. Although there are some patients for whom we might be concerned about screening for earlier than 10 because there are reports of type 2 diabetes earlier than the age of 10, it's not routinely recommended unless they have numerous risk factors that in that case you may want to consider screening. The screening should occur every 3 years. So as long as the tests are normal, you repeat that testing at a minimum of 3-year intervals. However, if their BMI is increasing or their risk factor profile is deteriorating, such as they develop signs of insulin resistance, you may want to consider more frequent screening. Those important risk factors that we need to be aware of per the American Diabetes Association include the following. So if a patient presents and they're 10 and up with either overweight or obesity and they have one of these factors, we go ahead and screen them. The first is a maternal history of diabetes or gestational diabetes mellitus during the child's gestation. The second is a family history of type 2 diabetes mellitus in either a first or second degree relative, so this could include parents, grandparents. The third is a high-risk race or ethnicity, so this includes Native Americans, African Americans, Latinos, Pacific Islanders, and Asian Americans. The fourth is any kind of sign of insulin resistance. So the classic example is acanthosis nigricans, or that darkening of the skin pigmentation around regions like the neck and the axilla. And then finally, conditions associated with insulin resistance, such as hypertension, dyslipidemia, polycystic ovary syndrome, or those who are small for gestational age birth weight. To make the diagnosis of diabetes mellitus, we use one of the following tests. And each test has its own individual benefits. So the A1C is a marker of glycated hemoglobin, which is basically a way of referring to the amount of sugar that's attached to hemoglobin within the blood cells. It represents a 3-month average blood glucose level for most patients. So it is going to help us determine what their blood sugar has been like over a several-month period. It's not going to be as appropriate for patients who have a more rapid red blood cell turnover, such as patients with cystic fibrosis. For patients that have an A1C greater than or equal to 6.5%, that's going to be indicative of diabetes. Now, of note, with the exception of the random blood glucose test, all of these tests must occur either with 2 separate tests on the same visit or a test that's repeated at a later interval. So a single A1C with the absence of any positives for the other values is not considered diagnostic per the ADA for diabetes. They would have to either repeat that A1C at a later date or also have an elevated fasting blood glucose or an elevated 2-hour blood glucose. The fasting blood glucose cutoff is above or equal to 126 milligrams per deciliter. For the oral glucose tolerance test, patients receive a 75-gram glucose load, and then the blood glucose levels are checked both at fasting and the 2-hour level. The 2-hour level, if it's above 200, is indicative of diabetes. And then finally, that random blood glucose test where the blood sugar is above 200 milligrams per deciliter at any given point in time, accompanied by classic symptoms of hyperglycemia. Those classic symptoms include increased thirst, or polydipsia, increased urination, or polyuria, unexplained weight loss, blurred vision, or fatigue. Now, of note, further diagnostic testing is typically done to determine whether or not the patient has type 1 diabetes mellitus or type 2 diabetes mellitus. And this would include testing for autoantibodies to one or more of the following: islet cells, insulin, glutamic acid decarboxylase, or insulinoma-associated antigen 2 and zinc transporter. I will now be turning it over to Dr. Graves to discuss a little bit more about type 1 diabetes mellitus.
As Dr. Lonnebaugh also mentioned, we are going to be talking about the pathophysiology and treatment of type 1 diabetes mellitus. First off, we're going to talk about the pathophysiology. In general, this is a quicker process, and patients often present with more classic symptoms of hyperglycemia, such as polyuria, polydipsia, unexplained weight loss, and blurred vision. They may also present in ketoacidosis. It's the most common form of diabetes in children. It is characterized by autoimmune destruction of pancreatic beta cells. They also have insufficient amounts of insulin produced in the body. This is distinguished from type 2 by the presence of autoantibodies against beta cell autoantigens. The workup for these patients includes laboratory testing for these autoantibodies. And the biggest thing we want to note that these patients are usually insulin dependent. And so obviously for the treatment of these patients, we want to give them insulin because they have insufficient amounts of insulin in their bodies. So first off is basal insulin. This is to cover the physiologic background insulin release. The second is bolus or prandial insulin. This is to cover meals or elevated glucose levels. But we also want to make sure that we're including lifestyle management in with these patients. This includes 60 minutes of aerobic activity daily and muscle strengthening at least 3 days per week, and carbohydrate counting, which we'll talk about later. For our treatment goals in these patients, an A1C of less than 7% is appropriate for many children. However, we do have acceptable A1C values of 6.5 through 8%. We use a lower A1C value of 6.5% if a patient does not have significant hypoglycemia or that if they don't have negative impacts on well-being or burden of care. The 8% is usually used for a history of severe hypoglycemia, limited life expectancy, or where the harms of treatment are greater than the benefits. We always tell other patients and their families to self-monitor glucose levels up to 6 to 10 times per day. We'll talk later in this presentation about technology that allows patients to allow this process to be more feasible for caregivers and patients. Next, we're talking a little bit about what insulin is and how it works. Insulin acts via specific membrane-bound receptors on target tissues to regulate metabolism of carbohydrates, proteins, and fats. It promotes uptake of glucose by cells, and it stimulates glycogen synthesis in liver and skeletal muscle. The main target organs for insulin include the liver, skeletal muscle, and adipose tissue. Within the liver, insulin stimulates hepatic glycogen synthesis. Insulin promotes hepatic synthesis of fatty acids, which are released into the circulation as lipoproteins. Skeletal muscle effects of insulin include increased protein synthesis and increased glycogen synthesis. Within adipose tissue, insulin stimulates the processing of circulating lipoproteins to provide free fatty acids, facilitating triglyceride synthesis and storage of adipocytes. Also, it directly inhibits the hydrolysis of triglycerides. In addition, insulin stimulates the cellular uptake of amino acids and increases cellular permeability to several ions, including potassium, magnesium, and phosphate. By activating sodium-potassium ATPases, insulin promotes the intracellular movement of potassium. Some adverse effects that we might note are hypoglycemia, weight gain, and injection site reactions. And there's 2 different dosage forms, including pens and vials. Normally secreted by the pancreas, insulin products are manufactured by pharmacologic use through recombinant DNA technology using either E. coli or Saccharomyces cerevisiae. Insulin glargine differs from human insulin by adding 2 arginines to the C-terminus of the beta chain, in addition to adding and containing glycine at position A21 in comparison to the asparagine found in human insulin. Insulins are categorized based on the onset, peak, and duration of effect, such as noted here: ultra-rapid acting, short-acting, intermediate acting, and long-acting. How do we start insulins in these patients? We want to start at 0.5 units per kilogram per day. We use lower doses for children in the honeymoon period. The honeymoon period is when someone first receives a diagnosis of type 1 diabetes mellitus and starts insulin treatment. Their blood sugar can stay at near normal levels and their diabetes symptoms vanish. Sometimes, as we said, it varies depending on the child, their needs, and their likeliness to experience hypoglycemia. We want to use higher doses for children if diagnosed around puberty. We would like to provide about 1/3 to 1/2 of the dose as basal insulin. We will also want to calculate the carbohydrate factors and correction factors, which we'll discuss later on in this presentation in the next slide. As I said earlier, we calculate the carbohydrate factor using the rule of 500. We do 500 divided by the total daily dose of insulin. The carbohydrate factor accounts for the amount of carbohydrates consumed. This defines the amount of insulin to be given for how many carbohydrates are eaten. The second one we want to look at is correction factor. We want to use the rule of 1800. 1800 divided by total daily dose gives us the amount of insulin to be given if blood glucose levels are above a pre-specified set point. However, we do note that there are slightly different numbers used for regular insulin, the rule of 450 and the rule of 1500 respectively. Let's run through a sample calculation. RL is a 10-year-old male with a newly diagnosed type 1 diabetes. He will be started on a long-acting and rapid-acting insulin. His weight is 28 kilograms. First, we want to calculate the total insulin dose. And if we remember, we want to start at 0.5 units per kilogram per day. So 28 kilograms times 0.5 is equal to 14 units total insulin dose per day. Next, we're going to calculate the long-acting or the basal dose. So we're going to want to do at least 1/2 to 1/3 of the total dose as long-acting. So we took half of that daily dose, so 0.5 times 14 units is equal to 7 units. This is how many units of long-acting basal dose that he's going to get. Next, we're going to want to calculate the insulin to carbohydrate ratio. This is 500 divided by 14 units using the rule of 500. This is equal to 35.7. But to make our lives easier and the patient's life easier, we're going to do 1 to 35. This means that the 1 unit of rapid-acting insulin will cover 35 grams of carbohydrates. And lastly, we're going to use the correction factor. This is the rule of 1800. So 1800 divided by the total daily dose, which is 14 units, is equal to 128.5. But again, we want to make numbers easier. So 1 to 130. So this means that for every unit of insulin, we have 130 milligrams per deciliter correction for his blood glucose. Now I'll be passing it on to Kevin for our type 2 diabetes mellitus.
So type 2 diabetes mellitus is a distinct presentation from type 1 diabetes mellitus. Here we are worried about two key things: defective insulin secretion by the pancreatic beta cells, as well as the inability of insulin-sensitive tissues to respond appropriately to insulin. It's also important to note that type 2 diabetes mellitus in the pediatric population is both distinct from type 1 diabetes mellitus, but it's also probably distinct from type 2 diabetes mellitus in the adult population. We expect that with type 2 diabetes in this population, a more rapid progressive decline in beta cell function, as well as accelerated development of diabetes complications. So those things like microvascular complications like nephropathy, neuropathy, and retinopathy, as well as macrovascular complications. Again, type 2 diabetes mellitus is really defined by this progressive loss of the pancreatic beta cells, according to that beta cell dysfunction, that's going to cause high levels of blood glucose over a sustained period of time. Oftentimes, the presentation is slower, so these symptoms are often less noticeable to patients. And it might be some of the signs of insulin resistance that are kind of more of our key targets. So things like acanthosis nigricans, hypertension, hyperlipidemia, as well as an increase in weight. In these patients, plasma glucose regulation is affected by multiple areas, and all of these areas are going to be potential targets for our treatment strategies. So one of the errors within type 2 diabetes mellitus is decreased insulin secretion. So in response to high blood sugar, the body does not release insulin in an appropriate manner and the blood sugar stays elevated. There's also increased hepatic glucose production, so the body doesn't recognize that the blood glucose level is high, and as a result, the liver continues to pump out extra glucose into the bloodstream. We also have decreased glucose uptake by the cells. So normally, insulin is responsible for an anabolic state where we're building up tissues, muscle, fat, all of that. And the cells use glucose to promote all of these activities. But with insulin resistance, they don't respond to it as well, and so you don't get that glucose uptake for action. And then finally, there's actually increased glucose reabsorption, and more glucose is absorbed into the bloodstream because the body's not recognizing that high blood sugar level. It's not responding appropriately. And above all, to contrast this with type 1 diabetes mellitus, we're really talking about insulin resistance, so the inability of the body to respond appropriately to insulin. The American Diabetes Association has a nice algorithm for how we manage these patients on an initial presentation. So we first off start by looking at their A1C. If their A1C is less than 8.5% and they aren't showing signs of either acidosis or ketosis, we're going to go ahead and start metformin, assuming their renal function is normal. That metformin is started at a lower dose and eventually titrated up to the higher dose of 2,000 milligrams per day, as long as it's tolerated, with GI adverse effects being the most commonly associated with metformin use. For those patients that present with an elevated A1C at baseline above or equal to 8.5%, we go ahead and start a basal insulin as well at that 0.5 units per kilo per day. that we saw earlier with some of our type 1 patients. That basal insulin would be titrated every 2 to 3 days based on self-monitored blood glucose levels. Now, you may hear this sometimes referred to as patients that are metabolically unstable. And again, that's just these patients that present with a particularly elevated A1C at baseline. Finally, for those patients that do have acidosis and are presenting in either diabetic ketoacidosis or hyperosmolar hyperglycemic non-ketotic syndrome, we want to manage that state, that ketotic state, and start IV insulin until the acidosis resolves. Then we can convert to a subcutaneous formulation, but we're going to continue on an insulin regimen until we've ruled out type 1 diabetes. So we then check pancreatic autoantibodies. For those patients that do not have or are negative for autoantibodies, metformin will either be continued or initiated if they presented with either DKA or HHNK at baseline. If they're on insulin, we're going to continue to titrate that insulin based on their blood glucose values. If they're treated with both insulin and metformin at baseline and they're meeting their glucose targets based on that blood glucose monitoring, insulin can actually be tapered off over a 2 to 6 week period by decreasing the dose by 10 to 30% every few days. However, if their goals are not met, we want to continue metformin and then consider adding on additional agents. So we now have an additional class of agents that are approved in the pediatric population for treatment of type 2 diabetes mellitus. So these are our GLP-1 agonists that we'll discuss further. But the guidelines have already incorporated these as additional agents to potentially consider in the algorithm. Another option is to consider prandial insulin if the patient is already using basal insulin and their glycemic target has not been met with escalating doses. Finally, if they're positive for autoantibodies, this is suggestive of type 1 diabetes mellitus, and we either want to continue our multiple daily insulin injections or initiate that multiple daily insulin injection, so that basal bolus regimen. For some of these patients, pump therapy might even be an option. And those patients that have positive autoantibodies, we're going to discontinue metformin because there is no evidence to support the use of metformin in this population. Metformin is really a workhorse in the diabetes realm. It's the only biguanide available in the United States, and its mechanism of action targets those key factors or those key problems that we're experiencing with type 2 diabetes mellitus. This includes increasing insulin sensitivity, so metformin assists in the peripheral uptake of glucose as well as the peripheral utilization of glucose. It's also going to decrease hepatic glucose production, so it's going to stop that liver from pumping out excess blood sugar when the glucose levels are already elevated. And then it's also going to decrease the intestines from taking so much glucose from a patient's nutrition. So we're not going to get as much absorbed into the bloodstream to have to funnel to other areas. Now, metformin's place in therapy and its role in the guidelines really comes from the Today study, which found that metformin alone provided durable glycemic control, in this study defined as an A1C less than or equal to 8%, for 6 months in about half of the patients. An interesting point is that the Restoring Insulin Secretion Consortium study, or also known as the RISE study, did not demonstrate differences in the measures of glucose or beta cell preservation between metformin or insulin. However, there was more weight gain with insulin, and in the type 2 population, weight gain is often a major concern. So for those reasons, metformin has remained our workhorse for pediatric patients with type 2 diabetes mellitus. We do have 2 additional agents that have been approved received an FDA approved labeled indication for type 2 diabetes mellitus in patients 10 years of age and above. These are liraglutide and exenatide. These 2 agents are glucagon-like peptide 1 agonists, or GLP-1 agonists, and they mimic the action of endogenous peptide, GLP-1, to promote the insulin secretion in response to glucose. So again, when glucose levels are high in the bloodstream, these agents are going to signal the body to pump out more insulin in response to help bring down those blood sugar levels. Additionally, they can be helpful by promoting pancreatic beta cell growth and replication. So kind of overcoming some of that dysfunctional problem and progressive loss of function that we saw with type 2 diabetes. They're going to decrease a few things as well. So they're going to decrease the inappropriate release or secretion of glucagon. Now, glucagon is responsible for promoting the liver to release extra glucose into the bloodstream. And by shutting off that glucagon secretion, we're decreasing the amount of blood sugar available in the bloodstream, or blood sugar levels. And then finally, they're going to actually promote earlier satiety. So they decrease gastric emptying and food. They can decrease food intake, promoting a sense of fullness. And this is why these agents also have some role, perhaps, in pediatric obesity, with liraglutide in particular receiving an FDA-labeled indication for this under the brand name Saxenda. This chart is really for your reference to kind of help review the dosing, side effects, and contraindications, but I do want to point out a few important points. Again, metformin is started on a low dose and titrated up, generally because of those GI side effects, including nausea, vomiting, and diarrhea. We do have both immediate release and extended release preparations. The immediate release preparations are often given twice daily, the extended release preparations given daily. And it's thought that the extended release preparations also may have some benefits when it comes to the GI side effects associated with metformin use. Metformin does have some rare side effects that we should be aware of. So there is a risk of lactic acidosis, particularly in those patients that have severe renal dysfunction or hepatic dysfunction, which is oftentimes the reason why we hold metformin in the inpatient setting. There's also a risk for vitamin B12 deficiency with long-term metformin use. A clinical protocol for metformin is that it should be held for 24 hours prior to surgery and then 48 hours after, assuming renal function has been restored. And again, that relates to the risk for lactic acidosis associated with either renal insufficiency or hepatic insufficiency. Our GLP-1 agonists are given as subcutaneous injections, but they do have slightly different dosing regimens. Liraglutide is a daily subcutaneous injection that has to be titrated on a weekly basis up to the maximum dose of 1.8 milligrams, whereas exenatide is actually a once weekly flat 2 milligram dose. They also have GI symptoms as pretty common, which makes sense given that they promote that early satiety or early fullness feeling. So the nausea vomiting is not altogether surprising. They probably have less diarrhea compared to metformin, however. And because they're injections, we do see the risk for injection site reactions. Rarely, but significant to consider, include acute kidney injury, gallbladder disease, and pancreatitis. And there are contraindications for the use of these agents with patients that have either a history or family history of medullary thyroid cancer, or patients that have multiple endocrine neoplasia syndrome type 2. Additionally, some clinical pearls for these agents are that liraglutide, we really want to make sure that the patient's consistent with use, because if they miss more than 3 days of the injection, they have to restart at the base dose of 0.6 milligrams daily. And then for exenatide, we worry about patients with renal dysfunction, as it's not recommended to be used in patients with a GFR of less than 45. Finally, our treatment goals for patients with type 2 diabetes mellitus mimic those treatment goals that we saw with the type 1 population. The ADA has really tried to standardize these treatment goals, and so patients are going to target an A1C of less than 7%. It should be individualized and reassessed every 3 months. For many patients, less than 7% is reasonable, especially in the wake of all of our emerging technologies that Logan is going to talk about here in just a moment. And the amount and frequency that patients are going to self-monitor those blood glucose levels and how they do so is going to be really individualized to the patient as well as what their treatment regimen is. So more intensive treatment regimens involving things like insulin are going to involve obviously more monitoring than perhaps just all oral agents. So I'll now turn it over to Logan, who will tell you a little bit about how we've had some pretty exciting updates in the world of diabetes technology.
So as Dr. Lonavos said, we have many different areas where we can actually do self-monitoring of blood glucose. This could be a whole entire topic in itself, so we'll briefly just talk about it just generally. So we have two different types. We have blood glucose meters and continuous glucose monitoring, or CGM. The blood glucose meters is a point-in-time measurement of a patient's blood glucose value. It's often used around time of initial diagnosis. It's very important for those with intensive insulin regimens to make sure they're not going too low or too high of blood sugar, and then the less evidence for use with basal insulin only regimens or only oral agents. The continuous glucose monitoring, however, is useful for patients with multiple daily injections or continuous insulin infusions. This provides an overall picture of glycemic control. It reduces occurrence of hypoglycemia, and then it utilizes interstitial glucose values. The interstitial glucose values are determined by the rate of glucose diffusion from the plasma to the interstitial fluid and the rate of glucose uptake by subcutaneous tissue cells. So as we know, there are different types of CGMs that are available out on the market. So these are two different types, Freestyle Libre 2 or the G6. As we can tell that they're so different. They have different times associated with FDA approval, how long the sensor can be worn, and how long the system takes to warm up before the scanning can begin. Each of these can be just patient-specific or based off of your preference as well. But as you can see, this is just a table for your reference to note any FDA approval, the wear time, and the warm-up time. And as we know, there are also insulin pumps that are available. Technologies are rapidly evolving, and the latest pumps integrate CGM data to automatically adjust basal insulin release rates. So they're very interesting, and they're actually very cool for patients to develop so they don't have to prick themselves multiple times a day. So as I said, who really should be on an insulin pump? Youth and adults with type 1 diabetes and other types of insulin deficient diabetes. We can also consider offering to youth and adults with type 2 diabetes and who are on multiple daily insulin injections. As I said earlier, we don't want to have to be pricking our child or even ourselves multiple times a day. So having this insulin pump really helps with the adherence of insulin for children and adults. Now I'm going to turn it over to Dr. Lonavos to talk a little bit about hypoglycemia.
Thank you. So hypoglycemia is a really important topic for patients with diabetes, especially those treated on insulin. Given that hypoglycemia is one of the major adverse effects we're concerned about, we want to know what hypoglycemia looks like and how we're going to appropriately treat it. Hypoglycemia is also really important because it can influence the treatment intensity for many of these patients as well, as those that have either hypoglycemia unawareness or those that have frequent episodes of hypoglycemia may have less intensive treatment targets. So by sheer definition, hypoglycemia is defined as a blood glucose value of less than 70 milligrams per deciliter. And it's defined by these symptoms. So shakiness, dizziness, sweating, hunger, irritability, and confusion or changes in thoughts or behaviors. Now, of note, patients that are on concomitant beta blockers may not show all of these signs, and really that sweating becomes the most common, the most important one for a patient that's on a beta blocker. When we think about treating hypoglycemia, we want to refer to the rule of 15. And that's going to both give us the amount of carbohydrates or sugar that we have to replenish, as well as when we recheck the blood glucose. So the rule of 15 means that for a blood sugar that's less than 70 milligrams per deciliter, we're going to give 15 grams of carbohydrates, which can be found in approximately a half cup of fruit juice or regular soda. Really, really key, because a lot of these patients are conscious of the amount of carbohydrates that they're taking, that it's regular soda and not diet soda, as diet soda is not going to give them any benefit in terms of raising their blood sugar. We can also administer glucose tablets or glucose gel. And the exact recommendations are going to be a little bit product specific, but in general, that means about 3 to 4 glucose tablets or 1 tube of glucose gel. We can consider using sugar or honey, just a single tablespoon of either of those products. Jelly beans or other hard candies are also an option. What's not an option is anything that's going to contain additional fats or proteins, as that's all going to slow down the amount of blood sugar that's absorbed into the bloodstream and kind of slow down that whole process such that it takes too long really to raise the blood sugar. So while peanut butter crackers might be a great option for patients that are going to need to stay out of hypoglycemia in the long term, they're not an appropriate choice for this initial treatment phase. Patients should then recheck their blood glucose in 15 minutes, and if it's still low, they actually are going to have to redose with an additional 15 grams of carbohydrates. So glucagon is an option. Remember, we talked about this earlier, as impairment in glucagon, natural glucagon activity can actually be related to some of what's going on with diabetes mellitus. But we also have exogenous products to help promote blood sugar delivery in cases of severe hypoglycemia. Again, glucagon works by promoting that liver to break down glycogen and release glucose into the bloodstream, as well as to go through the process of gluconeogenesis. Glucagon is really only indicated for severe hypoglycemia, so these are going to be patients that are going to be non-responsive. It's going to be a caregiver or that's going to be administering the doses of these agents. And so adverse effects for glucagon can include some pretty significant GI side effects, including nausea and vomiting after receiving the dose, or a headache. We're in a kind of exciting time for glucagon because there are multiple dosage forms available to us now. For the injectable formulations, there's a pre-filled syringe, which is new. It used to be just a product where you had to mix right on the spot in preparation for the dose. And so now that we have this auto injector, we have another option for us. And there's also a nasal product that's now available. The dosing regimens are generally 0.5 to 1 milligram. It's a little bit product specific. There's generally a lower dose and then a particular weight cutoff, at which point patients receive a 1 milligram. The intranasal is a 3 milligram dose per one actuation. And then finally, if we were to administer it in the inpatient setting, we have weight-based dosing recommendations of anywhere from 0.02 to 0.03 mg per kg, up to a total of 1 milligram. So we'll now finish off by going over a few self-assessment questions to ensure that we've covered the material in sufficient detail to prepare you for experiences with patients with either type 1 diabetes mellitus or type 2 diabetes mellitus. So our first question is, which type of diabetes is characterized by a loss of beta cells and subsequent insulin dependence? And so our options here include type 1 diabetes, type 2 diabetes, cystic fibrosis related diabetes, or maturity onset diabetes of the young. And I'll give you just a moment to consider your answer. So the answer to this first question is type 1 diabetes mellitus. Remember, type 1 is defined by a true insulin deficiency because of an autoimmune process that destroys those beta cells. So these patients ultimately lack all production of insulin and need some kind of exogenous source in order to be treated effectively and to actually safely lower blood glucose levels. And contrasting that to type 2 patients who are defined more so by inability of insulin-sensitive tissues to respond appropriately to insulin and insulin resistance. And Logan is now going to cover question number 2.
So question number 2, which of the following is a long-acting insulin? Our choices are A, Lispro, B, Aspart, C, regular, and D, glargine. I'll give you a few minutes to think over your answer. And the answer to our question is D, glargine. If you refer back to one of our tables that actually goes through all the different type of onsets and peaks and durations, you'll find that glargine is a long-acting insulin.
So question 3 is a case-based question. Here we have an 8-year-old female with type 1 diabetes mellitus. Her carbohydrate factor at lunch is 1 to 20, and her correction factor is 1 to 100 with a target blood glucose of 100 milligrams per deciliter. So she has lunch at school, and today she's planning to eat 60 grams of carbohydrates. When she checks her blood sugar, it's 200 milligrams per deciliter. So how many units of insulin should JM receive as a bolus? So to answer this question, we need to think about some of the math that we were going over earlier. Remember, patients with type 1 diabetes mellitus are going to have a carbohydrate factor as well as a correction factor. That carbohydrate factor, we really need is going to reflect how many units of insulin are given for a particular amount of carbohydrates consumed. In this situation, the carbohydrate factor is 1 to 20, and our patient wants to consume 60 grams of carbohydrates, which means that she'll need 3 units of insulin to cover that meal. Additionally, we need to consider the correction factor. So if the patient has an elevated blood sugar already, we need to administer some insulin to account for the fact that she's already well above her target, even and to account for both the amount that she's eating as well as that elevated blood glucose. So in here, our current blood sugar is 200, which is 100 milligrams per deciliter above our target of 100. It's nice how that math works out. Her correction factor of 1 to 100 means that because we're 100 off our target, we need to add an additional 1 unit of insulin for correction. So the correct answer is 4 units because we have 3 units of carbohydrate coverage and 1 unit of correction coverage for a total bolus of 4 units.
Question 4 is also another case-based, but not as math-intensive. TJ is a 12-year-old male newly diagnosed with type 2 diabetes mellitus. His past medical history includes asthma. The patient's A1C is currently 8%, and the current random blood glucose is 175 milligrams per deciliter. He has normal electrolytes and kidney function outside of his elevated blood glucose. He also has a normal urinalysis. Which agent is the most appropriate choice for TJ at this time? Our choices are A, insulin glargine, B, liraglutide, C, metformin, or D, exenatide. I'll give you a few minutes to decide on your answer. And the answer is C, metformin. If we remember back to Dr. Lonabaugh's discussion, metformin was pretty much the mainstay of therapy for patients with type 2 diabetes. GLP-1 agonists such as liraglutide and exenatide are usually supplemental to metformin. Same thing with insulin glargine. Patient is obviously not on metformin currently, so starting metformin right now would be the best option for TJ at this time.
So our 5th question is which of the following is an approved non-insulin medication for pediatric patients greater than or equal to 10 years old with type 2 diabetes mellitus? And our options here are dulaglutide, liraglutide, canagliflozin, or glyburide. So the correct answer here is liraglutide. It's one of our newly approved GLP-1 agonists, which has made its way into the ADA guidelines for use in pediatric patients with diabetes mellitus. Dulaglutide is another GLP-1 agonist, although it does not yet have any kind of pediatric labeled indication. Canagliflozin is belongs to a class of medications known as SGLT2 inhibitors, and while you've probably heard of them because of the massive interest in their use in adult patients with diabetes mellitus, we don't have the evidence or the FDA labeled indication to use them in the pediatric population at this point. And then finally, glyburide is a sulfonylurea that just does not have pediatric approval.
And our last question, which of the following is a sign or symptom of hypoglycemia? Our choices are A, weight loss, B, confusion, C, increased urination, or D, polydipsia. And the answer is B, confusion. If you want to have an easy way to remember what hypoglycemia is, think about symptoms you may feel when you haven't eaten in a while. Shakiness, dizziness, confusion, and hunger. And then we always know that polydipsia is extreme thirst. That's a symptom of hyperglycemia. Same thing with increased urination. Weight loss obviously is not as a symptom of hypoglycemia. So we've concluded our presentation. However, I want to go over some key concepts that we've discussed over the topic of this presentation. First, type 1 diabetes mellitus is characterized by insulin dependence, and type 2 diabetes mellitus is characterized by insulin resistance. Second, treatment options and goals vary based on the needs and presentation of the patient. And lastly, improvements in diabetes technology have led to an increase in the use of continuous glucose monitors and insulin pumps, particularly in patients with type 2 and type 1 diabetes. Here are some additional references that you may look at after this presentation. We thank you for attending this Pediatric Diabetes Core Competency.